Usinawe mkono hata usiende chanjo, taka tupolela, usijikinge, sahau. Afya yako jukumu lako, daktari atakata pesa yako.
Health is wealth, and the government invests substantially in the provision of health services. Good quality lives depend on community behavior norms that promote health and prevent diseases. The involvement of the community in matters pertaining to the people's health is an important component in the reduction of the disease burden. Prior to the introduction of the community health framework, morbidity and mortality rates, especially among the children, remained high.
As I said, we studied community health in medical school. I qualified in 1973, and I already had a postgraduate diploma in education by the time I qualified in medical school. And so I was actually invited to teach in the medical school from 1974. And from that moment, I decided that community health was going to be my main area of interest. And my research area was then community health. So I carried out research work in the 1974 and even 75, and by 1976 I had formulated what we called the community-based healthcare approach. I wanted to have a system where we work with the people in the community and leave them there to continue to improve their health, to continue to prevent disease, to continue to promote health. So I began doing that work in 1975. By 1976 I had my project was formalized, and I carried out that project between 1976 to 1982. And it was actually designated as the national pilot project for community-based healthcare by the Ministry of Health. It just happened that at the same time in 1978, there was going to be a major conference in Alma-Ata in the former USSR on primary health care. And since my project was the only project that had data and experiences on community health, I wrote the paper for the government of Kenya to present at Alma-Ata. So Kenya was represented with work from my project. The Alma-Ata Declaration that came from 1978 endorsed this fact, the fact that you can work with health facilities which are of the lower type, dispensary, and they were closer to the people, dispensaries and health centers, and work with the people themselves so that they can themselves relate to the health facility and improve their own health. And this only happened because in 1994 to 2004 was the health policy framework. And that health policy framework was envisaging that it would include great improvements. It would show at the end of 2004, it would show great improvements of health indicators like maternal mortality, child mortality, the burden of disease in communities. It was assumed that it would be much less by 2004. But when the evaluation was carried out after 10 years, 1994 to 2004, when the evaluation was carried out, it was found that it is just the opposite had happened. Maternal mortality was worse off than it had been in 1994. Child mortality was much worse than it was in 1994. And the burden of disease was much worse, was getting worse and worse. And why was this? This was because you cannot they were focusing on health facilities only. You cannot improve health by focusing on health facilities. Health facilities are for curing disease. But if you want to improve health, you have to focus on the communities where people actually live so that they are not getting sick.
I joined the ministry as Director of Medical Services at the end of 2003. So the first year, we mainly were working on the situation analysis, what was happening in the ministry, how programs have been running, and then we embarked on development of a strategic plan that was to carry us for the next 4 years. And it is during this time of the situation analysis and preparation of the strategic plan that we realized that there has been a lot of money that has been invested in healthcare, but the indices, the health indices, indicators, were actually showing a deterioration over the past years. It is at this time that we try to find out what exactly can we do with the money that was available. I consulted a number of people on what is really the best way to get the best results with the resources available. And the people I consulted were Professor Miriam Were and Professor Dan Kaseje of Great Lakes University. And in the consultation of both, we actually came to the conclusion that what has been known for a long time, that investment in public health and community health has not been done. And so with a lot of detailed discussion, particularly with Professor Dan Kaseji, we came to the conclusion that it is time that we tried a community health approach as a principle on investing more in public health.
Today, the Community Health Strategy, CHS, has evolved into community health services and is recognized as the foundation of the health system. It is an approach by the health sector in Kenya through which communities participate in their own healthcare and development, as summarized in the CHS slogan that reads, "Our health, our responsibility. Afya yetu, jukumu letu."
The first thing we did was really to design a community-based plan that was suitable for Kenya. So we actually designed the structure of it, the unit, how the unit should be, how big the unit should be, how many people in the unit, and how many community health workers were to be put in place, and how to link the community health workers with the health system.
As we start to think through how we are going to implement the community strategy, it became important that we form governance structures. It is through this Interagency Coordinating Committee that we actually even put in structures that would be and ensure that we mobilize resources to be able to facilitate the implementation of community strategy. And I would say by large, it was a very, very exciting time. I think I saw one of the most enthusiastic groups that I've ever worked with. People were very upbeat about implementation of community strategy. Everybody who was in the group, in the Agency Coordinating Committee, felt that the time had come for community strategy to be implemented, and they were very, very upbeat and enthusiastic about it.
There was a lot of volunteerism in this country from the community health workers and from the community health extension workers who really supported the idea of communities managing their own health.
Under the community health strategy, health services are delivered through a community health unit with a given population of 5,000 people in about 1,000 households. In most cases, a CHU is about the size of a sub-location. The community health strategy was first mentioned in the 2005 to 2010 National Health Sector Strategic Plan 2, and it was launched in 2006. Division of Community Health Services was placed under the Ministry of Public Health and Sanitation when the health ministries were split into two in 2008.
In 2009, we formed a technical working group which under responsibility of providing policy direction in terms of community health strategy matters. But later on, in 2010, it was converted into now an ICC. And these ICCs were formed from all partners that are interested in working at level 1 at the community, and then the Ministry of Health.
Through this committee, actually, we managed to mobilize adequate resources. I think we got to develop to establish units from 0 to 2,551 by the time the Ministry of Public Health and Sanitation was coming to its life cycle end. So to start, the cost of developing one unit is very high. To develop 2,551 within a span of 4 years, to me that was a very tall achievement.
The partners concentrated very much training the workforce now, the community health workers and the community health extension workers. That was not a small effort, it was a lot of resources which were used. But let me say also the government supported a lot together with the partners in providing resources to develop the data collection tools which were not there at that particular moment.
The deployment of community health assistants, previously known as community health extension workers and community health volunteers, previously known as community health workers, has greatly enhanced health service delivery to the people.
When we started the community strategy, the sanitation coverage we were at 83. Right now, it is a reading in sanitation at 98%. So I am associating that one with the community strategy. The community health workers being the workforce at the community level, identifying the household without sanitary facilities, more specific the toilets, putting much of the emphasis, and at the wrong end, having the product, the output is the toilet.
What's more, such services are dispensed in a familiar, friendlier manner, the challenges encountered in the process notwithstanding.
Nimeona community ikifaidika na mambo ya usafi hivi. Kwa mfano, watu wamejua kujisafisha mikono, wamejua hata kufungua manyumba, na wakaanza kutumia hizo net.
An evaluation exercise conducted in 2010 since the CHS was initiated showed a significant improvement in community health indicators. This has largely been made possible through the participation of key stakeholders who include donors such as UNICEF, JICA, USAID, and Global Fund.
I've been working in different African countries and Asian countries, and I've seen big impacts when communities are involved. And then I also believe that a solution is within us.
Our organization is about child's rights. So we endeavor to see that every child is born healthy, every child survives, every child thrives and develops to reach their full potential. For that to happen, it means that we need to ensure that the child is supported at the different levels to reach that level. The mother is also supported to be able to give birth to a healthy child. And we know that in Kenya, why many children are not surviving is because of basic causes, things that are predictable, things that are preventable.
We have achieved a lot as a country. And I can look at it backwards and say we have now community health units, very functional, and we have some that are also having what we call IGS, income generating activities. So they're able to consolidate their resources also as well at that level. And we have seen some good milestones in terms of health services indicators, where we have seen through community health units, uptake of services like antenatal care, malaria, preventive care like nets and the likes. We have also seen reduction of diarrhea cases among children in communities where units are operating. We also seen uptake of HIV services, counseling, treatment, and care also. And I would say that through that, this achievement that could not have been achieved through other services or other approaches, but through community health, we have seen a lot of inputs and successes in this area.
Community health strategy has really helped us in terms of improving health indicators in the county, especially in the area to do with skilled delivery by skilled birth attendants. and also in the area in nutrition, because we have been making use of CHWs in our facilities in terms of taking weights and other providing other nutritional services in our facilities. And also in referral, at least we are seeing more mothers coming for ANC services.
Partners have been instrumental in the provision of technical and financial support towards the development of the CHS standards, CHS community strategy, M&E plan, revision of community health information system tools, and the community health strategy documents, as well as production of training manuals for CHVs and CHAs. These documents have been developed through workshops and pre-testing at community settings.
One of the biggest first milestone was we organized first national conventions where we invited, I think, almost 200 people from Kenya, all the communities, at that time 8 provinces, as well as also we invited a few countries outside of Kenya to share lessons learned, best practice, even challenges.
One lesson I've learned is that working as a team, when people work as a team, and in terms of partnership, it brings a lot of synergy, and that synergy can make actually a lot to be achieved within a very, very short time. The greatest achievement which I can say is actually the production of this document you can see over here. This is not just a document, but what I'm saying is the achievement of getting a cadre that is specifically working at level 1 under the name of Community Health Service Personnel.
Policymakers are now working together with the communities to produce different evidence, all the different kinds of evidence in community health services. And now we have 3 sites: nomadic, urban, rural, because people realize that Kenya is so diverse. We cannot talk about one example, and we need to really be inclusive of all when it comes to the implementation of this strategy. So now I think we established, or rather strengthened, evidence-based policy cycle. So nowadays people talk about evidence, when we cannot make any guidelines and tools unless we have evidence.
These community health workers, are we going to pay them or are they volunteers? And by the time I left the ministry, we were feeling that we need to give them some token of appreciation for the work they do, but they should not be formal employees because they are members of the community.
The most critical aspects of community strategy is actually, getting the teams that are within the unit and the teams that are in health promotion working closely together. And as we work closely together, we look at, the facilities that the referrals are channeled to, and we also link them together. So what it calls for is that the Directorate of Preventive and Promotive, under which community strategy lies, works very closely with the Directorate of Clinical Services, because we know that health is a continuum. It is not disintegrated into pieces. It is a continuum. So it starts from the household and it continues up to the facility. And that is something that we have recognized. And we, even at the director level, we have agreed that really for us to be able to move forward in terms of giving health, assuring every Kenyan good health, is that the 2 directorates must work together.
The biggest lesson, of course, is that most people who are in the policy aspect do not understand, and that's why they don't give money. This year we want to form 6 units, and it's within the budget for this financial year. So the support is there. The problem are the resources, which are not enough. So we spend more money in curing, because you can't stop curing people and say, let's go on prevention, right? It has to be progressive.
As it is now, community health services is an administrative structure that is based on policy, more on policy than a legal framework. There is no legal framework for it. There is no, for example, recognition of those units in law except administratively. The role of a community health worker has not been defined by qualification, by function in any legal document.
At the policy level, national level formulates guidelines and tools, policy formulation, and then implementation happens at the county levels. So that means there are two different governments which need to work together. First things I think the government should really focus on is really to do a big sensitization to the county, advocacy sensitization, actually to share lessons learned and best practice impacts, positive impacts of community health services. It works so that county government can put or secure budget to implement community health services.
The more attention the counties will pay on the future, on their community health services, the healthier their people will see. They will see that the people in the counties will become very healthy. They will see that the disease expenditure on health will begin to go down because people are healthy and there is not much expenditure on diseases. They will see that now children are growing in a healthy way, mothers are not dying, and we also, as part of the community health services, family planning becomes more common and more prominent all over Kenya, because we know that when a mother has children very close together, her health is affected. She cannot be very healthy.
Community health services is actually about empowering the individuals and the communities and the household to take care of their health. Devolution is doing exactly this. We have now taken the power, the resources, the decision-making and the implementation process, and active or constructive engagement of the community to the grassroots level. So for me, devolution actually is an answering the community empowerment.
The future, at least now with the support of the county, the devolved unit, at least we have money within the county we can be able to budget and make use of the resources. So there's a lot of light in the tunnel. What we need is also the stakeholders to come. What I can say, we are not very lucky as a county in terms of stakeholders funding community health services, because I think due to insecurity, but we urge the stakeholders and other donors to come on board so that we can achieve our objective of improving community health services in the county.
Community health services is probably the most important thing that the counties can undertake. And if more money is put in the community health services, the community strategy, I think we will have a bigger yield, as I said, in terms of improvement of health. And it will actually reduce the cost of health at a county level, eventually at a national level. And therefore, it is important that the county governments are actually, one, sensitized on the value of community health services, community strategy support. 2, supported to embrace and implement the community strategy. And 3, financed to do the same.
The greatest lesson I've learned is that we need more sustainable interventions and consistent, because right now we are mainly donor dependent, so most of the time the activities done by community health workers in the units are not that consistent because they're mainly donor dependent. So we need to, as a county, to bring stakeholders and have a kitty so that we most of our activities become consistent and the effect is felt throughout.
What would ask is continued and sustained support to community health services, because if we are to strengthen and if we are to reach and achieve the health indicators and the targets that we've set, it has to start at the community level. We have to invest at the community level in terms of the capacity of the health personnel at that level, in terms of the numbers, because we need more people, especially the trained health workers, who we call the community health extension workers. We need more support to get more recruitment at that level, and this is a plea especially to the county governments, because health has been devolved, and it is the mandate of the county governments to recruit. It's a plea we are making that they recruit more of the community health extension workers because of the critical role that they are playing at that level. I see community health services here to stay because it's part of our health sector service delivery, and it's one of the critical levels that if we fully invest in, then we are able to achieve the health outcomes we all endeavor to achieve, and we are able to reach our goals as a nation.
The future of CHS is bright, it's brilliant, especially with the devolution of services to the community level, because now we'll see more and more interventions at that level coming out, and more resources, especially at the county level, coming out to support the health services. And this, I would say, is a bright future to me. It's a future that everybody would be proud of when you look at these interventions at the community health services.
The Kenya Essential Package for Health in the Health Sector Strategic and Investment Plan 2013 to 2017/18 defines health services and interventions to be provided at the various levels of care, ranging from the community, sub-county or primary care, county and national level. At the community level, over 2,000 community health units have so far been established. There is still a lot to be done, since by the year 2017, over 4,526 community health units are expected to be in place. In all this, success depends on the combined efforts of all concerned, that is, the government, development partners and other stakeholders who include health workers, community health volunteers and community members. Overall, community participation holds the key to creating a resounding impact in the health sector.
Afya yetu, afya yetu, afya yetu, jukumu letu.
Ndio, afya yetu, jukumu letu. Afya yetu, jukumu letu. Afya yetu, afya yetu, afya yetu, afya yetu, afya yetu, afya yetu, jukumu letu.